Thank you, everyone, for coming back from lunch on time. We did want to now start session 2 of our workshop. So the focus will be on the potential consequences of deviating from one or more existing product characteristics. And to begin this session, we have Wade Delk from Protecting Access to Pain Relief Coalition.
Thank you all. I'm very privileged and pleased to be here. Let me just tell you a couple things about the Protecting Access to Pain Relief Coalition. We were launched in 2015, so we're coming up on our 10 years next year. And it's a multi-stakeholder coalition formed to advocate for public policy to support access and to choice and appropriate over-the-counter pain medications. And we provide education and updates to both to patients, the Hill, different departments, HHS, NIH, across the board. And it's a multi-stakeholder, like we were saying, so it's across the board, about 17, 20 different organizations. Groups include pharmacy and gerontology, nephrology, kidney, and then the group that I represent as well, which is, I needed to say this too, didn't I? So as far as conflict of interest, Johnson & Johnson, which is now called Kenvue, does provide administrative support, but our organizational members contribute their time, energy, and expertise for no additional or for no charges whatsoever. So again, here's the information about the coalition I was talking about. I sort of preempted it already, but the organization that I represent is the American Society for Pain Management Nursing within the Protecting Access to Pain Relief Coalition. And this organization is well over 30 years old and is brought together by different nursing organizations or different nurses who wanted to make sure that the pain management space and the education and training for other nurses could be carried on by this organization. And about 40% or so of the members are, in fact, advanced practice nurses. But one of the things we like to say as far as pain management goes is all nurses are pain management nurses. And I will tell you, too, that one of our great presidents of the organization, Dr. Joe Eland, the University of Iowa, back in the 70s, even just, it seems like it's just back in the 70s. I know for some people it might be longer ago than that, but for me, it doesn't seem like it's that long ago. But we have really come a long way, because back then, and she was a strong advocate for that, babies and children are incapable of expressing and feeling pain. That was a lot of the myth that was out there. And so she went well over and above to make sure that they understood effective pain control in children. So she'd be very pleased that we are here today talking about it in greater detail. So one of the challenges that I have now is that much of what I was going to say, and I'm still going to say some of it, was handled this morning. And then I thought, well, I've got a few things left, and then the panel talked. So that created another thing. However, I'm going to do just a little bit and reinforce some of the things that they said and maybe bring a couple of new things into the mix. We'll see. So as we discussed, there's different levels of physical development between boys and girls, and there's a large variance in weight and development, in the different spaces. So that creates a thing: is age-based better than weight-based? And are there confusions from one child to the next? So we had, you're looking at different concentrations. So if you have a different concentration of a medication in one child, you may, in fact, unintentionally give that wrong dose to the other child, because you're sort of making those guesses, right? Okay, I think I know what we're doing. We're going to make that guess. So saying weight-based dosing is more accurate is probably true, right? Because you see the different sizes. Jody talked about her 3 daughters and the different ranges in that particular space, and then that goes between boys and girls, as well as girls and girls and boys and boys. It just is different. But when you say it's easier to understand, that's sort of a loaded question in some ways too, because if you're talking about age-based, that's pretty easy to understand. My child's 7, my child's 9. But then my child 7 weighs 80 pounds and my child 9 weighs 50 pounds. So now we're back to weight-based again. And I put this really in here, does everyone have a scale? More as like a sort of a comedic kind of thing, because we make the assumption that they do, so they know what that is. And when was the last time they went to their primary care provider that they got weighed? I mean, the next choice they could do, I guess, is go to the carnival and say, get the guy to weigh him at the carnival, guess my weight. But that's kind of an issue, and I think overall, with all the things that we're talking about and doing, that we need to make sure that we're providing this great information and clear information to those individuals that are charged with providing this medication as well. And, I've seen some different discussions both in the nursing space and the doctor space across the board. But when we tell someone what they need to do, go take some over-the-counter medication, go take, Advil, go take Aleve, go take Tylenol. We're not telling them necessarily that exact amount because on the adult dose, it's pretty straightforward. It's clear. But in the children's dose, it all of a sudden brings in that question. And I know, I think, Ian, you might have been talking about it before, but, the 2 and 3 and 4-year-olds, a lot different than 6, 7, 8, 9, 10. So that creates a challenge, and that's a big, broad challenge. So we need to provide exact instructions, not just general instructions, especially in this space. One of our nurses gave me a list of all the different breakouts of this age and this weight is this and this. I mean, it's like this long. And so she's like, maybe you should tell them about that. I said, maybe I should, but I think if I just say it, I think they'll probably get it because it is very difficult to understand what people should be doing and what these caregivers should be doing. Now, acetaminophen and NSAIDs, they're the backbone of pain management. And we know there's a problem with undertreated pain. It also can create additional emergency room visits, doctor visits, nurse practitioner visits. And it also, if you think about it in the bigger space, it talks loudly to the availability of healthcare resources. So we're overusing these resources because we're not necessarily providing these medications appropriately. And I know a lot of us have already have talked about this, but low medical literacy, that's a big, big problem. I mean, even, I don't know if anybody does this, but I'm going to say they don't for the most part. What to look for? What are the toxicity symptoms to look for if you're giving your child too much? I don't think we sort of relay that information. I'll just give them another dose. We got to be careful about that ceiling because once they hit the ceiling, more doses doesn't do anything to help. It actually does things to hurt. So we have to be careful there. So the labeling, this is, several of our people that we did the survey from our organization, our members, they said, you know what, they get the medication, they open it up, they throw the box away, and if they don't have it on the bottle, they won't know. And if they might do at that immediate spot, they'll know because it was on the box is gone 3 months later, look at the bottle, it's not on the bottle, they're done. So we need to make sure all the places we think it should be that they're there. So you see here about the proficiency in English. One of our nurses said to me, let me tell you a story that's going on. I'll make it very short. But when individuals come in with low proficiency in English, and she's in the metropolitan New York area, they're telling them, go out and take an over-the-counter medication. It's about as much as the information as they give them. So they go out there, they get that one piece of medication. When they look at the whole shelves of them, the tons of them there, they decide, okay, I'll get this one. And they get that one, they go home and they give it to their individual child. And then another child, older or younger, needs it as well. Like, I'll guess, because they told me to take this, so I'm going to guess what that is. We talked about other consequences that happen too: missed school, poor academic performance, poor sleep. And, one of our nurses likes to talk about the authorities that everybody seeks, and that's Dr. Mom and Dr. Google. That's what happens. And these, the parents, which we all were a part of, I also thought too that, all these people that are in school right now, and they go, why do I need math? Why do I need science? Because you're going to be a parent and you're going to have to figure out these dosing limits. That's why you need all those things. So make sure that you do that. But again, everybody seems to have the familiarity with over-the-counter medications. So it doesn't seem like, if I give them 2 or 3 extra, not a big deal. Yes, it is. We need to educate. Again, going back to that clear point of medical literacy. So when we're talking about inpatient, that's the very controlled environment that we have. But the outpatient that is using more of the over-the-counter medications, that's where it's more difficult. And there's difficulty, as we said, in understanding the dosage. So what our people do in our particular space, both with the coalition and the nurses themselves, is they really try to educate caregivers, parents, caregivers, on the drug facts label and the active ingredient, which needs to be prominently displayed. So just a couple of stats here. 30%, this is all in adults, 36% likely to use multiple OTCs of more than one symptom if they have sore throat, cold, toothache, that sort of thing. less than 50% read the over-the-counter label, and 26% read define the active ingredient. So these are the individuals that are that are charged with providing that information and providing those medications to their children. Post-surgery, there's not always the dosing that's given to, asking about different hospitals across the country, there's not always given that dosing after discharge. So one of the things that's very clear is stronger medication has a very clear dosing that they leave the hospital with, but the OTCs that they're asked to provide and give to their children doesn't necessarily make it very clear for them. So that can create a problem, creating stronger medications. Dosing intervals. Creates confusion combination, cannot dose differently. That's one of the key things that our people said, and in proper pain management, you don't want the medication to wear off. If the medication wears off, you potentially could have to get stronger medication to get back up to speed and get the pain under control. But also, you're creating a situation where you don't need to do that with the combination. And I'm not saying anything specifically against combination medications. I'm just talking about some of the lessons that are learned with that. We had this one story about an individual who had the pain, and they were given a combination medication. And then they all of a sudden had allergy symptoms. So they gave them another medication for allergy that had some of those same medications in it, and it sort of rinse and repeat. Turns out they were actually allergic to one of the medications in the combination medication that they didn't even know. So that is one of the, the issues with these things put together. And again, you're getting, and I know we talked about this before, but more medication than is needed. But the other thing is you might get more medications needed, but which one worked? We might not know which one was the one that worked. So you did it one time, oh, it worked this time. 6 months from now I have the same problem, so I'm going to give it to them again. And again, with combinations, they require reducing medications if, obviously different medications are for, have problems with kidney and liver issues, so it's harder to balance those. So a major children's hospital uses this breakout to talk about the milliliters given. They have this information that they share with the caregivers, and they go back and forth between acetaminophen and Motrin or ibuprofen, back and forth, but they keep track of this. And again, they provide the exact schedules to the parents and caregivers, the times, the dosage, next day, all these different, max a day and the next things of that nature. And this has reduced, as I was saying, the need for stronger medications. So again, the delivery mechanisms, liquids are great, but again, milliliters, those types of things, they're more prone to errors. Orally disintegrating tablets, very popular. Those could be around. That creates, much greater ease. Concentrated medications, less is better. But again, if you're having trouble giving the child the medication, if it's more in a concentrated space, not necessarily long-term, but in a concentrated space, it's easier to get that medication to them. But let's talk one other thing about topical, and I know Casey talked a little bit about topical in her presentation as well, but let's say you have a girl who's playing soccer, she has a sports injury, she hurts her leg, they rub topical on there, whatever the medication that topical is. Then she goes home and says, Mom, my leg hurts. Oh, here, take this. Now she's just gotten double dosed with that particular thing because the parents aren't or the caregivers, it's not clear what they have, what they've already taken. So again, we need to consider medication refusers, and then those with cognitive and developmental delays, clearly an issue. The patches, one thing that's interesting, and I know this would require FDA to speed up, the things in the pipeline, but the College of Pharmacy at the University of Iowa has done a lot of research on this. They've got a lot of information out there about that, and they're working on it. But again, I know it's not for children yet, and that would require another piece. So really, avoid confusing and guessing. Educate healthcare providers, especially nurses. Now, we heard, Diane talked about that as well. You call the nurse hotline. Well, that's the people that they're reaching out to. That's the next step if you don't know what to do. So make sure that we actually have our providers very clear on any new medication and even clear on current medication as well. Because we know that when these medications are dosed properly, they're very safe and effective to treat fever and pain as well. I'll leave you with this, but the room for error is much smaller with children. We all know that. So you can't quite experiment on them the same kind of way you can for others. So with that, this is our coalition leadership. This is our staff, and thank you for your time.
Thank you, Wade. So our next talk will be co-presented virtually by CDC PROTECT, or Prevention of Overdose and Treatment Errors in Children Task Force members, Maribeth, Sivilus, an epidemiologist from CDC, and Captain Jennifer Lind, pharmacist in epidemiology from CDC's Medication Safety Program.
Good afternoon. So my colleague Maribeth, Sivilus, and I will be sharing some of the strategies, challenges, and innovations that CDC is using to prevent pediatric medication overdoses that may help inform some of today's discussions. Next slide. I thought IT was going to share our screen for the presentation, but do you need us to share? If so, I can do that. 1 second. Hold on. 1 second. Heather, if you're on the line, do you all have our slides to share on your end? Or LOD, one of the AV support persons?
If you let me know which one on the deck I can share.
Yes, it is the slides that are titled Preventing Pediatric Medication Overdose Strategies, Challenges, and Innovations.
Do you have a slide number for me?
If you can start it from the beginning, do you have the deck, or is it a part of a larger?
Part of a larger deck.
Deck. Yes, perfect. Thank you. All right, and if you can just go to the next slide, please. All right, thank you everybody for your patience. So in the medication safety program, where we work to protect patients and members of the community by leading CDC surveillance activities for national tracking of adverse drug events and other drug-related harms, and translating data into targeted prevention actions through collaboration and communication. So how does adverse drug event surveillance happen? It's based on good old-fashioned chart review. The adverse drug event study is called NICE-CADES, which stands for the National Electronic Injury Surveillance System, Cooperative Adverse Drug Event Surveillance Project, and it is a collaboration between CDC, FDA, and the U.S. Consumer Product Safety Commission, who operates the NICE system. NICE-CADES is an active population-based surveillance system. Currently, NICE-CADES is based on a national probability sample in approximately 80 hospitals, and the sample is stratified by size, and there is one stratum for children's hospitals. The data are weighted so that we can generate national estimates of ED visits and subsequent hospitalizations for adverse drug events. Next slide, please. So this chart is from an analysis that was published just after we began adverse drug event surveillance using the NICE-CADES data. Here you can see that the population rates for emergency department visits for adverse drug events by age group. And as you might expect, we saw increasing rates with age, but something we did not expect to see was that the rate for the youngest age group, those for children younger than 5 years, was similar to the rate for older adults. And when we looked at these data more closely, we found that most of the ED visits in the youngest children were for unintentional medication overdoses. Next slide. In the early 2000s, we saw that the number of young children brought to the emergency departments for unintentional medication overdoses and exposures was rapidly rising, and it increased by 40% from 2004 to 2010. To put these numbers in perspective, a child born in 2007 had approximately a 1 in 54 chance of being brought to an emergency room for an accidental medication overdose or exposure by the age of 6. Next slide. While these unintentional exposures were quite common, the good news is that they are preventable. And so in 2008, we convened a group of individuals working in this area, and we created the Prevention of Overdoses and Treatment Errors in Children Task Force Initiative, otherwise known as the PROTECT Initiative. PROTECT is a CDC-led public-private partnership that uses a collaborative, data-driven approach to reduce harms from unintentional medication overdoses in young children. Partners include public health agencies, private sector companies, healthcare professional organizations, consumer patient advocates, standards organizations, and academic experts. Through Protect, we use a three-pronged approach to reduce unintentional pediatric overdoses by 1, improving safety packaging to reduce unsupervised ingestions, 2, standardizing labeling to reduce medication errors, and 3, updating educational messages about safe use and storage of medications for new generations of caregivers. Next slide. So how can we prevent adverse drug events among young children? As mentioned earlier, most of the emergency visits for adverse drug events in young children were for unsupervised exposures. And despite the requirement for child-resistant packaging for most medications in the US, around the time that the Protect activities began, there were over 60,000 emergency department visits annually for unsupervised exposures by children under the age of 6. We know that child-resistant packaging only works when it is used appropriately, which it means when the safety cap is fully secured after each use. And it is a technology that has changed very little since the 1970s when it was first implemented. So Protect partners began to explore how safety packaging might be improved. And we began by focusing on prevention of oral liquid OTC medication exposures because we already had partners at the table who were engaged and willing. There were relatively small numbers of products, and many of the products were intended for pediatric use. Protect partners came up with the idea of using bottle adapters as flow restrictors to act as a secondary barrier that would always be in place to limit the amount of medication that young children could access on their own. They are designed to be used together with child-resistant caps. And here you can see an announcement from Johnson & Johnson in 2011 stating that flow restrictors would voluntarily be added to pediatric acetaminophen products, and other manufacturers of pediatric liquid acetaminophen made a similar commitment at that time. Next slide. So since flow restrictors were first introduced, they were tested with young kids and were proven to be effective. Studies using poison center and emergency department data have found that they are also effective in reducing the number of exposures overall and the number involving potentially toxic amounts of acetaminophen. An American Society for Testing and Materials standard test method was developed to assess flow restrictors using mechanical testing. And FDA released a draft guidance in 2020 that recommended broader use of the restricted delivery system, such as a flow restrictor, to help further reduce the risk of unintended oral liquid drug ingestions. The guidance specifically mentions diphenhydramine and cough and cold medications as potential candidates. And since these are products that have a high frequency of harm based on the NICE-CAIDS data, we are encouraging broader flow restrictor use through Protect. Next slide. Through Protect, we continue to encourage innovations in packaging for both the primary containers, which is the packaging that the medications is in when you receive it from a pharmacy or the store, and then also the secondary containers, which is the container that adults might transfer medications to intentionally. The top two images shown here on the slide show interventions for primary packaging, which are different types of flow restrictors for liquid medications and unit dose packaging. And then the bottom image shows a design for a locking pill organizer that is on the market. Please note that to our knowledge, it has not been tested for child resistance, but several companies who participate in Protect are working on different versions of a child deterrent or locking pill organizer, and we expect that some will come to market soon. And some are also working to take the concept of flow restrictors and then applying them to solid dose medication packaging. Next slide. As previously mentioned, emergency department visits for adverse drug events are relatively common in children less than 5, and the vast majority of those emergency department visits are due to unsupervised ingestions. However, a small portion of emergency department visits among the young children are due to medication errors. Medication errors are most common among the smallest and most vulnerable children, shown here in red, and these are children less than 1 year old. Next slide. And so this table just illustrates how administration mix-ups could lead to a multifold medication overdose or underdose error. So I won't go through each of the examples. However, I will note that when multiple different units are used, such as milliliters, teaspoons, tablespoons, and other units, these can often be confused. Next slide. Clearly and consistently showing milliliters only on liquid medication packaging, labels, and dosing devices can minimize errors when measuring and giving doses. Protect partners have initiated and led a number of activities to improve labeling on medication bottles and dosing devices, and have participated in related activities led by partner organizations. Through Protect, partners have encouraged education for prescribers to increase the use of milliliters only when prescribing and dispensing oral liquid medications. We've also worked to educate parents and caregivers to use the dosing device that comes with the child's medicine, such as the oral syringe or dosing cup, to make sure that they get the right amount. We've also worked with Protect partners to encourage production of milliliter-only dosing devices to minimize errors when measuring and giving doses. Next slide. The third prong of our three-pronged approach for Protect is focused on safe storage education. In December of 2011, we launched the Up and Away and Out of Sight educational program to update and disseminate educational messages nationally. In addition to the tools, resources, and materials available online at upandaway.org, we have rallies that are held at certain time points throughout the year to extend the reach of our messages about safe medication use and storage, using a variety of media channels such as print and online articles, social media, radio, and video. We encourage our Protect partners to help us reach broader audiences by sharing the rally messages with their networks. Next slide. Our core Up and Away messages have historically centered around several simple data-driven actions that parents and caregivers can take to prevent medication overdoses in children. These include, 1, putting medicines up and away and out of children's reach and sight, putting medicines away every time, making sure that safety caps are locked, teaching your children about medicine safety, telling guests about medicine safety, and being prepared in case of an emergency. So the question is, with all of these interventions mentioned, have we seen any improvements in emergency department visits among young children? I'll now turn it over to my colleague, Maribeth Sivilus, to discuss recent trends. Maribeth? Maybe Maribeth, it might be having difficulties. Maribeth, jump in if you are able to, but I'll keep going. So we're going to start sharing some recent data. So in recent years, we have seen overall declines in national estimates.
Thank you, Dr. Lyles.
Okay, go ahead. Maribeth, if you're talking, we can't hear you. Okay, I will take back over. But in recent years, we have seen an overall decline in national estimates of emergency department visits for unsupervised medication exposures by children aged 5 or younger, from approximately 76,000 ED visits in 2010 to about 36,000 visits in 2020. Next slide. So when we looked at trends in ED visits for unsupervised medication exposures by medication class, we found declines in estimated visits for many classes from 2009 to 2012 to 2017 to 2020. This table shows trends and estimates of ED visits for solid dosage form medications. The green arrows on the right indicate classes for which there were significant declines, and the red arrow indicates a class for which there was a significant increase, such as herbals and alternative remedies. When we look more closely at the medications within this class, next slide, we found that the increase was driven by a substantial increase in ED visits for melatonin exposures. The next slide. So next, we look more closely at these ED visits for unsupervised melatonin exposures by young children and compared them to visits for exposures involving other medications. Next slide. And we found that the ED visits for unsupervised melatonin exposures involve slightly older children than visits for exposures to other medications. Over half of the visits for melatonin exposures involve children 3 to 5 years, whereas only 25.9% of visits for unsupervised exposures to other medications involve this age group. So nearly 3/4 of visits involving exposures to other medications were made by children aged 2 or younger, which include developmental stages when children are gradually increasing their mobility and learning about their environment by putting things into their mouths. But as children get older, they become more selective about what they put in their mouths, and they may seek things that interest them, We've seen case narratives indicating that children in this age group climb to reach medications and even move chairs or stools to help access them. For emergency department visits involving exposures to melatonin and also those involving exposures to other medications, approximately 46% involved female children. In an estimated 94% of emergency department visits for unsupervised melatonin exposures, the child did not require subsequent hospitalization. For visits involving unsupervised exposures to other medications, approximately 81% did not require hospitalization. So the ED visits for unsupervised melatonin exposures seem to be less serious. For emergency department visits involving exposures to melatonin and those involving exposures to other medications, approximately 87% involved access to a single medication. So 87% of the visits for melatonin exposures involved only melatonin and no other medications or supplements. Next slide. In a more recent analysis, we reviewed narratives of emergency department visits for unintended melatonin exposures by children aged 5 and younger to identify circumstances involved in these ingestions to help guide development of interventions. And we found that in nearly all, which was 96% of the ED visits for pediatric melatonin exposures, the child accessed a solid dose formulation of melatonin. Next slide. Gummy formulations were the most commonly documented dosage form involved in about 47% of these ingestions. However, an unspecified solid formulation was documented in approximately half of visits. So although we do not know their specific formulation for all visits, we know that gummy formulations were commonly implicated and that these products and the chewable tablets containing flavoring and other attributes that may make them more appealing to young children. Next slide. And we know that many medications might look like candy. You can see some examples here of common lookalikes in the image on the right, which we use as a part of our Up and Away education campaign that focuses on safe medication use and storage. Distinguishing the medications or supplements from the candy can be difficult even for adults. And so this graphic is a reminder to parents and other caregivers that if they cannot tell the difference, children probably can't tell the difference either. And so it's important to keep all medications in a place that young children cannot reach or see. Next slide. And after finding the increase in emergency department visits for unsupervised melatonin exposures, we updated our safe storage messaging for the Up and Away campaign to specifically include gummies. This message now reads, keep medicines, vitamins, and other supplements, including gummies, in a safe place that young kids can't see or reach. And I believe next slide. And that is our last slide. Thank you.
Thank you, Jennifer and Maribeth. Our next speaker is Kate Reynolds, pharmacoepidemiologist and member of the CDC Protect Initiative from the Rocky Mountain Poison and Drug Safety. Thank you.
Little trek over here. Thank you for having me today. I'm Kate Reynolds, Director of Research at Rocky Mountain. I want to explain a little bit about what Rocky Mountain does. So we are an organization that provides a number of different services, primarily oriented around medication and drug safety, as well as specialized research. Our medication safety services are really oriented in our poison center care. We have been operating a continuous poison center for nearly 70 years now, one of the largest in the country. So that really kind of orients us to our overall mission. And I run the research unit, which provides a number of different services, but primarily around post-marketing surveillance, including doing medication safety studies, which I am going to talk to you about today. I'm going to walk through some of the pediatric acetaminophen safety changes, which Maribeth and Jennifer described a little bit earlier. I'm going to talk about the impact of those changes as they relate to acetaminophen exposures, and then I'm going to describe kind of what we know about medication errors and how they happen with these OTC drugs. Just to note that the research I'm going to describe here today was funded through an investigator-initiated study award from Johnson & Johnson, which is now Kenvue, and they make Tylenol. Okay, The first point was already made by Dr. Hindeman earlier this morning, which is that analgesics are the second most common type of exposure in kids under 6. In 2023 specifically, those involved almost 60,000 unintentional exposures, or what Jennifer and Maribeth were referring to as, I believe, unintentional ingestion. So that's when a little kid gets into a medication, they're not supposed to access it, they might drink some of it or all of it, and that's a very common exposure reported to poison centers. And about 30% of those are medication errors, which we spent most of our day talking about. When we drill into those analgesic exposures, 51% actually involve single ingredient ibuprofen, and another 41% involve single ingredient acetaminophen. Really, really importantly here is that only 1% of those single ingredient ibuprofen and single ingredient acetaminophen medication errors involve an admission to a healthcare facility. Lots of calls to poison centers, but by and large, these are very, very safe in children. And some of that is due to the work around improving safety, which I'm going to talk a little bit more about now. So though analgesics are the second most common exposure now, when I looked back at the last decade or so, they were always in the number 2 or 3 of top type of exposure in kids reported to poison centers. And in 2011, specifically, there was a large initiative to start improving some of that as it relates to single ingredient liquid acetaminophen. That involved implementing these flow restrictors, which Jennifer showed you earlier in her earlier slide, so I won't explain those anymore. Standardization of the concentration, and so prior to 2011, you could buy an infant's concentrated formulation, which included 80 milligrams of acetaminophen per 0.8 mLs of liquid, as well as a children's product, which was 160 milligrams per 5 milliliters of liquid. And when you do the math, the infant's formulation actually equated to 500 milligrams for 5 milliliters. You can imagine that would result in errors that involved a large volume dose for some children. Another change was using the ml only on the dosing units. Jennifer described the potential risk there as well. Getting the confusion between teaspoons and milliliters is very common. The inclusion of impact standardized dosing devices. Essentially, every time you buy an infant's product, you will get a calibrated syringe, and if you buy a children's product, you will get the calibrated or standardized dosing cup. And then a number of other sort of best practices were implemented at this time as well. So my team wanted to know whether this worked. And so we took on a number of different studies to assess whether these safety changes affected the rates of medication errors. We also looked at unintentional exposures, but for the sake of this conversation, I'm going to really focus on those medication errors. We looked at data from 2007 to 2016. We included kids that were under 12. And we included exposures reported to poison centers with a reason code of unintentional therapeutic error. If you're interested, the definition is there at the bottom, but that is essentially how poison centers categorize medication error exposures. For those of you who are not familiar with poison center data, just a little blurb here about that. There are 55 U.S. poison centers that provide free medical information to poison patients and their healthcare providers. So a parent can call, another caregiver can call, a healthcare provider can call and receive free medical advice any time of the day. When I'm talking about a call or an exposure, that's essentially equivalent to one person or one case. So just keep that in mind. And then another thing that's really important to keep in mind with poison centers is that just because a call happens doesn't mean somebody was injured. When it is an actual exposure, it means someone had a contact with the medication, but it doesn't mean that they had some clinical event. Okay, so here's the first data slide. So this slide shows us those exposures or cases of medication errors reported to poison centers from 2007 to 2016. That top line is in exposures under kids under 2. The lighter blue dotted line is kids 2 to 4. The dark or the solid light blue line is 4 to less than 6, and then the hollow line is kids 6 to less than 12. Overall, we saw a 19% decrease in medication errors involving liquid acetaminophen, with the largest decrease in those kids less than 2 years of age. There's a 24% decrease in that population. It's important to note that the less than 2 remains the highest proportion of medication errors, which I think is consistent with the data that Jennifer presented earlier as well. And there is not label dosing instructions on pediatric liquid acetaminophen packaging, so something to keep in mind there. All right, and then this is another figure from this study, which shows us how exposures changed in relation to the availability of medications. So the solid black line is exposures, and just note that the axis there on the left doesn't go down to 0. So we didn't wipe all of those exposures out, but just for scale purposes, it made it a little easier for us to see here. The top line, the top dotted line, is sales of the 160 milligram products, and the bottom dashed line is sales of the infant's concentrated 80 milligram products. You can see that the sales really took off with the 160 milligram products in about 2011, and the sales really decreased almost to 0 there by 2012 with the infant's concentrated product. And the decrease in overall exposures to poison centers were really proportional to that decrease in availability of that infant's concentrated product. So I showed you the trends and the sort of first layer of the onion here as we try to assess the impacts. But we wanted to understand what was really going on here. And so we did some what we refer to as root cause work. But when we think about this a little more broadly, we try to identify these preventable factors to medication errors. So what we did was a survey at 6 regional poison centers. And we completed a phone survey which was about 15 minutes long. So somebody would call in, a parent, caregiver, and say, you know, I gave my kid this wrong dose and I need help, and the medical provider at the poison center would provide that care, complete all of the documentation, and then they would call them back within about a day or 2 and conduct this very focused survey around the event that took place. We conducted surveys between August and December 2019, or August 2013 through December 2019. We looked at only the single ingredient products, so none of the combinations or anything like that. And we only conducted surveys in caregivers, so we weren't calling back to healthcare providers. We completed 2,294 surveys in that time, and I just want to point out that almost 96% of those involved liquids. I think that's pretty proportional to the overall sales, but they do represent the large volume of the medication errors that are reported to poison centers with acetaminophen. So when we categorized all of the data, here were the top contributing factors or root causes. These are the things that help us identify what could be prevented to prevent the error. So the top category, which I'm not sure anything we're doing here today will change, is about a quarter involved just confusion between caregivers, multiple caregivers, overlapping doses, or getting confused about when someone gave what. About 19% gave the doses too close together, so they mixed up a dosing interval, may have read the instructions wrong, something like that, and gave the doses too close together. Just 12% said, I misread the instructions, that's how this error occurred. 10% confused the units of measure, which is confusing things like milliliters versus teaspoons. 4% gave the wrong medication altogether. And 2% of them roughly mixed up ibuprofen and acetaminophen explicitly. 2% used a non-dosing device to measure the medicine. This was tied to the inclusion of the impact dosing device, so that's happening pretty infrequently, which is good to see. And 2% gave too many medicines with acetaminophen, which is another general concern. So overall, what we learned through all of this work is that the removal of multiple concentrations was associated with a reduction in poison center calls. You know, this really means that standardization reduces errors. Reducing variety in the number of products and their characteristics reduces the burden on parents, and they commit fewer errors. Other contributing factors included dosing interval errors, errors interpreting the label or dosing instructions, confusions about units of measure, using the wrong dosing device, and mixing up medications. I want to just point out, too, from my earlier slide, that it's really important to note that ibuprofen and acetaminophen as kind of the current safety profile associated with their availability results in very few actual injuries to children. And so it's just an important thing to think about as we introduce more variability here. How will the safety profile change? And one other thing that's not on my slide, and I just want to point out, which Jennifer did a good job of talking about, is inevitably new products lead to accidental ingestions, and so doing everything up front as possible to eliminate those things from happening. Things like flow restrictors and so forth will be really important to preventing those types of unintended consequences. And that's all I have. Oh, just a note about limitations as a good researcher, spontaneous data, those kinds of things, and some references if you're interested. Thank you so much.
Thank you, Kate. And our next speaker presenting virtually is Dr. Petrea Cober, a professor of pharmacy practice with subspecialty training in pediatrics at the Northeast Ohio Medical University.
Let me know if you can see my screen, the correct screen.
Yes.
Okay. When you have dual screens, you start worrying about which one is showing. So yes, my name is Petrea Cober, and I'm a professor of pharmacy practice at Northeast Ohio Medical University. And today, I really want to talk about the potential pharmacist perspective of any changes to existing product characteristics. So I have a few disclosures to include. And our learning objective for this session is to discuss the practical needs for extensive communication and education prior to any changes in existing product characteristics. So let's think about current caregiver confusion. So I think the best example of this currently about kind of like a test subject of what can happen when we don't provide enough information and education and communication is potentially ibuprofen. So unlike acetaminophen, which is available over the counter in one concentration, ibuprofen is currently available on the market as 2 concentrations. We have a more concentrated infant ibuprofen, which is 40 milligrams per ml, and we have a children's ibuprofen, which is 20 milligrams per ml. And this causes a lot of confusion among parents because they don't recognize a difference between the 2 products. And acetaminophen comes as an infant and a children's product, but with the same concentration. Ironically, we were actually having our first year pharmacy students yesterday do an over-the-counter lab project. And this was one of the tables that we had in that session. And several of the students also did not realize that these 2 products were different concentrations until we had them do the actual math revolving around that. So if students don't notice it and they're enrolled in pharmacy school, we have a lot of concerns about what potential parents and caregivers also are aware of. So I'm going to give you a real world example. As a pharmacist and as a mom myself, I was at the store and I was purchasing some over-the-counter items when all of a sudden I heard another caregiver. They were sent to the pharmacy by their significant other to obtain some ibuprofen for their infant. And unfortunately, it was during one of those periods of time in which ibuprofen and acetaminophen were having shortage issues. And so the store did not have any available infant ibuprofen, which that caregiver was used to purchasing. So the caregiver asked the store pharmacist for some advice and guidance on the use of children's ibuprofen. Now, I'm just the bystander standing there looking at other products for my own family when I am overhearing this conversation. And it was actually quite concerning because despite the fact that the pharmacist was trying to discuss the dosing of this different product with the caregiver repeatedly kept on saying, I give the same amount of mLs as I always do, correct? And the pharmacist would say, no, this is a different product concentration-wise, but you will give the same dose, but it'll be a different amount of mLs that you'll give to your child. Again, the caregiver would keep on repeating, so I give this amount as I always do. And the pharmacist kept on saying no. And I thought for 1 minute I was going to have to step in and be like, yeah, I'm a neonatal pharmacist. Do you need any help in this situation? But it seems like after about 4 or 5 tries, the caregiver finally understood that it was going to be the same drug, the same dose, but a different quantity. So I think this is a great example of how ingrained some of these aspects are for our patients that are out there in the community. So another thing I frequently see, and I believe this was brought up earlier this morning in having multiple products in a house, is there's also confusion amongst what you have when you have multiple children. So let's say you have a family, there are 2 children. One child is 9 months old, weighs 6.5 kilos. You have another child in the family that's 3 years old and weighs 14.5 kilos. What is the likelihood that they're actually going to have 2 bottles of ibuprofen, one for infants and one for children? And if they do, are they actually going to use the correct product for the correct child that they're taking care of at that particular moment? So let's think about this for a second. Education is extremely important. You can actually go to healthychildren.org, which is sponsored by the American Academy of Pediatrics. And with our recent shortage of various over-the-counter products, people were just trying to get whatever they could get. And so what was created for people was a dosing chart of the various different types of products that are available for ibuprofen. Gave weight ranges, gave age ranges, and then showed what you would give of each of the different products to try to show you how they're equivalent. So education is out there, but do you always have that education readily available? Are you able to utilize it when multiple children in your family may be sick all at one time? There may be a lot of sleep deprivation, and you accidentally grab the incorrect product. With this in mind, let's think about our case. So let's think about dosing for this patient. And I'm just going to use the dosing on the back of the box as opposed to what I would typically do is give a dose based on the milligrams per kilogram to start with, and the dosing range I know as a peds pharmacist. So you would be a caregiver. You'd have the 9-month-old, weighs 6.5 kilos. So for that size, the caregiver would give 1.25 mLs of the concentrated infant product to provide 50 milligrams. That would then provide 7.7 approximately milligrams per kilogram per dose, which would be well within the range for the use of ibuprofen. The 3-year-old child weighs 14.5 kilos. They would receive a 5 ml dose, which would be 100 milligrams of the children's ibuprofen product, providing an appropriate dose of approximately 6.9 milligrams per kilogram per dose. Now, let's say that inadvertently, this caregiver accidentally switches products and uses the incorrect product for one of the 2 children. So if both children use the infant product, which is more concentrated, the 9-month-old will get the correct dose because that's the product that is designed for them. However, the 3-year-old child will receive an overdose because for those same 5 mLs, if they get the same, dose amount that they would be recommended, it would provide them with 200 milligrams, and that would be 13.8 milligrams per kilogram per dose, which is a potential overdose for that patient. If on the flip side, we give the children's product to both patients, the 9-month-old, if they receive the 1.25 mLs, will actually get half the dose, or 25 milligrams, and so will be approximately 3.8 milligrams per kilogram per dose. So they potentially could be underdosed and not have a therapeutic benefit related to whatever their issue was, while a 3-year-old will be correctly dosed. So you can see using the incorrect product for the other child brings in the potential for either overdose or underdosing, depending on the child in which it was given to and which product it was. So I always like to think about what is a good example of a past product which had similar situations. And acetaminophen stands as a good example. And I know people have already mentioned some of this information previously. But before 2011, and I remember this, there were two products, just like there was for ibuprofen. There was an infant acetaminophen, which is 100 milligrams per ml, and a children's acetaminophen, which is currently available at 32 milligrams per ml. In 2009, the FDA recommended going to one concentration to avoid caregiver confusion and any concerns for unintentional overdoses. The Consumer Healthcare Products Association decision was then to go to this universal concentration in 2011. Education was provided in 2011 by the FDA and is available on the internet for looking at, and in 2015, actually provided recommendations for products that are over the counter containing acetaminophen, kind of like a guidance document for the industry, which is also available on their website. So if you look at that guidance document, they did reinforce that recommendation of a 32 milligram per ml concentration, which is usually, a lot of people refer to that as 160 milligrams per 5 mLs. They recommended clear labeling of the concentration, clear labeling of the age and units of age, clear dosing recommendations only in milliliters, so eliminating that teaspoon, tablespoon issue, and then images of the dose delivery device, as well as including an appropriate dose delivery device with the product and marked in the mLs in which it is dose recommendations. So what are the concerns for improper dosing, even with acetaminophen? So as ironically presenting after me, we have the study by Yin and colleagues in 2010, and they assessed parents' administration errors by dosing instruct type and exam degree to which parents' health literature influences dosing accuracy. When they had a cup with printed markings versus a cup with etched markings versus a dropper or dosing spoon or oral syringe, they had great variability of dosing within 20% of the recommended dose, with the best being from things that we typically recommend as pharmacists, droppers, dosing spoons, or oral syringes. This was further investigated from a health literacy perspective in 2019 and found similar findings. But education makes a big difference. So even back in 1997, we saw this as a true reason why we need to have good communication and good education, no matter what we decide to do for our products. So in this study, the objective was to determine whether parental errors in dosing liquid medication can be decreased through education. They had 3 groups, one in which you just received a prescription and the verbal instructions. 2, you got a prescription, a syringe, and you were shown how to do the dose. And then 3, prescription, a correct dose was actually marked on the syringe, and you were provided a demonstration. This resulted in higher accuracy as you provided more information to the parents. And after a month follow-up, 23 of the 26 still were able to demonstrate that correct dose from that 3rd group. So it stuck with them from that standpoint. The only thing I will caution is I've actually seen a lot of parents come back in with these marked syringes, even though their child's dose has changed multiple times, they're still using that same syringe they were given maybe even 2 years ago, marked for a dose previously. They like to stay within those parameters that have been set for them. So whenever the dose changes, you need to make sure that you either remark a new syringe or provide a lot of education surrounding that. Again, I think healthychildren.org is a great resource. They actually teach about the use of liquid medications for children and the importance of differences between things like 0.5 mLs versus 5 mLs, not using teaspoons. A lot of people don't realize that home teaspoons have anywhere between 3 and 7 mLs in them, and that's actually why we recommend the use of syringes. So if changes are made to our over-the-counter products that we currently have, we definitely need to provide good communication about those changes, making the public aware of that, and then having very detailed education in regards to this. And I would actually advocate for this not only being within the caregiver realm, but also within the providers that prescribe these medications or recommend them, even if they're over the counter, as well as pharmacists, because many pharmacists become quite concerned when you see a pediatric patient or a caregiver come up and ask questions about pediatrics, it's unfortunately within the pharmacy school education, pediatrics is not at the same, like, I don't want to say height, but it's not communicated as much as adult medications. And so unless you're a pediatric trained individual and you had pediatric trained pharmacists as your professors at your institution, you feel a lot more anxious about making these dose recommendations. So this would be very critical and important to any changes in the future. With that, I think we have questions during the panel discussion.
Thank you, Petrea. And our next speaker is Dr. Shonna Yin, an academic pediatrician with NIH and FDA-funded research on pediatric labels and dosing from the New York University School of Medicine. Welcome, Shonna.
Thank you. So as we think through non-prescription analgesic and antipyretic drug development in children, I think it's important to consider a health literacy perspective. So today I'll talk about health literacy and medication errors, existing areas of confusion that can inform our thinking, including around formulations, concentrations, active ingredients, dosing, and age restrictions, and end with some conclusions. So what is health literacy? Health literacy is the degree to which individuals have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. It includes the ability to access and navigate the healthcare system. When I think of health literacy, however, I think of health literacy being at the intersection point between the skills and abilities of individuals and where it meets the demands and complexities of the tasks that we put before individuals. Currently, the demands and complexities of the task of giving medications correctly to children is a significant health literacy challenge. Adding additional complexity by changing product characteristics will likely increase the risk of greater confusion and medication errors. So why is this a concern? There will likely be high rates of confusion given that in the United States, about a third of parents, or over 21 million parents, have the lowest levels of health literacy shown in red and orange, and very few parents, 15% shown in green, are proficient. That means the vast majority of parents in the United States face health literacy challenges. Caregivers with low health literacy have greater difficulty understanding prescription and non-prescription labels, are more likely to not be aware of weight-based dosing, are more likely to misunderstand active ingredient information, and are more likely to use non-standard kitchen spoons. Caregivers with limited health literacy have a 1.5 to 2.5-fold increased odds of making a liquid medication dosing error. With non-prescription medications, caregivers and patients often do not receive guidance from healthcare professionals. Caregivers and patients often thus must rely on their own health literacy skills or those of family members to determine which medications to purchase and how to appropriately administer them. Nearly 60% of U.S. caregivers report difficulty understanding OTC labels, with 1 in 3 reporting great or moderate difficulty. Parents with limited health literacy have a 3.4 times increased odds of reporting difficulty understanding OTC medication labels. I'll now talk about a number of examples from now and in the past related to how confusing the administration of medications has been for families, and we'll talk about how some have been addressed using a health literacy perspective. First area, having different formulations and concentrations, has been a significant source of confusion, as others have mentioned. In the past, liquid acetaminophen had 2 different concentrations, with the infant version being 3 times more concentrated. Liquid ibuprofen still has 2 formulations, with the infant version 2 times more concentrated than the children's version. Confusion with these formulations has previously been associated with cases of significant pediatric morbidity and mortality. In one study done before the move to 1 concentration of acetaminophen, nearly 30% of parents were unaware of the presence of different formulations of acetaminophen. And about 65% of parents thought the children's formulation was more concentrated than the infant formulation. My research team did a study of nearly 300 families, a large percentage who had low health literacy, and presented a hypothetical scenario where a doctor tells the parent to give 1 teaspoon or 5 ml of children's acetaminophen, and the parent had infant acetaminophen at home. About 80% would use the infant formulation, about 60% would have used a different dosing tool to measure out the medicine, and about 50% would have given a greater than 2-fold overdose of acetaminophen. This research was presented to the FDA Advisory Group Committee in 2009, and it was at part of that meeting where they voted to move to only 1 formulation of liquid acetaminophen. Ibuprofen continues to have 2 formulations, which remains a cause of confusion for parents. This article from the Institute for Safe Medication Practices documents a close call related to this. In a more recent study examining ibuprofen formulations led by a different researcher using a similar scenario as the previous one, about 25% made a dosing error. Luckily, resources exist to help parents navigate different formulations. As part of an AAP policy statement I led with Ian Paul and Dan Nussfield, we developed an implementation toolkit which included educational materials designed using health literacy principles to help parents navigate different formulations of acetaminophen and ibuprofen. Dr. Cober showed some of these pictographic charts in her talk as well, which are posted on the AAP's website, healthychildren.org. I'm going to shift gears and talk about active ingredients. When giving more than 1 medication, parents must determine if the same active ingredients are present. With pediatric cough and cold medications, acetaminophen is commonly included, which can lead to double dosing if parents are already giving acetaminophen. My team published findings related to an experimental study where we presented families with a hypothetical scenario in which a parent already gave acetaminophen to their child and now wanted to give a cough-cold medication. We found that only 1 in 3 made a correct choice of whether to give the medication, which was no different from chance alone. And only 1 in 5 who made the correct choice gave the rationale of overlapping ingredients. 1 in 5 who looked for overlapping ingredients made the wrong choice, and parents with low health literacy had 10 times the odds of making an error. That brings us to the question, can labeling changes improve parent understanding of active ingredients? In a randomized controlled experiment, we assigned families to 6 different groups, with each group exposed to 4 pairs of medications. We compared various approaches to labeling, including use of a standard list, groups 1 and 2, a list with an inset box, groups 3 and 4, and a list within an inset box that contained an explicit warning, do not give your child other medicines that also have these ingredients, in groups 5 and 6. The groups also varied by font size. We found no differences by font size, but we did find that there was a 3-fold increased odds of correctly determining whether 2 medications are safe to give together in the groups that got the explicit warning compared to the groups who got the standard list. We also found a 3-fold increased odds in the group that got the explicit warning versus the groups that got the inset box. No differences were seen in the groups who received the standard list versus the inset box. These findings suggest that labeling changes can improve parent understanding of active ingredients and hopefully how parents take action on active ingredient instructions. Appropriate dosing is another area of confusion, as Dr. Cober mentioned. Studies have found that about 50 to 60% of parents have difficulty determining the correct dose using the dosing chart, and only about 30 to 45% know that weight is the primary basis for dosing. Parents who know about weight-based dosing are more likely to dose correctly. The appropriate use of dosing tools is also a source of confusion. Some parents are unaware that they should avoid use of kitchen spoons, which vary widely in size and shape and are associated with higher rates of dosing error. There's variability, however, in the type of dosing tools provided to parents and that parents use, including dosing spoons, dosing cups, syringes, and droppers. For OTC products, dosing cups are most commonly provided. We did a study looking at how parents dose with a range of dosing tools, randomizing the order parents dose. This is a study that Dr. Cober mentioned as well. We found dramatic differences in how well parents measured a 5 ml dose depending on the tool used, with dosing cups associated with a 6 to 7 times increased odds of a large error. For an intended dose of 5 ml, the range of dosing was 2.1 to 23 ml with the dosing cup. Caregivers commonly make errors administering medications, with studies showing that over 40% of parents make dosing errors with prescription and OTC medications. Use of health literacy-informed counseling strategies can support parent understanding of correct dosing. For example, use of plain language pictographic instruction sheets as part of health professional counseling, along with demonstration and teachback and provision of standardized dosing tool, was found in a randomized controlled trial to result in fewer dosing errors, from about 50% of parents making errors in the standard care group versus 5% in the health intervention group. We also found decreased rates of non-adherence. While this study focused on prescribed medicines, there are lessons that can be applied to OTC medications related to how targeted counseling can benefit families. Even simply adding pictograms to labeling, a health literacy-informed strategy, can reduce medication dosing errors. One randomized control study involving nearly 500 parents showed that textless pictogram instructions were associated with a twofold reduction in large greater than twofold errors compared to text-only instructions. Finally, I'll focus on age restrictions. In 2008, the FDA issued a national public health advisory recommending cough and cold medications not be used in children less than 2 years old. This was further voluntarily extended to children less than 4-year-olds by manufacturers of OTC cough and cold medications. And the AAP cautions against the use of cough and cold medications until over 6 years old. But consumers continue to use cough and cold medications in young children, and consumer confusion is common. In this randomized control experiment, we sought to examine if labeling changes can improve parent understanding of age restrictions for OTC cough-cold medications. This study involved 300 parents who we divided into 4 groups, each of which were given 5 labels to look at within their group. Group 1 had no age information on the principal display panel, but had that information on the drug facts panel. Group 2 had basic age information. Group 3 had basic age information with an explicit safety warning that it was not safe to give to children aged 5 and under. And Group 4 had basic age information plus an explicit warning plus a pictogram. We found that there was a 4-fold increased odds of correctly determining that the medication was safe for their child based on the age information in the group who got the explicit safety warning versus the group with no age information on the front panel. There was a 2-fold increased odds of correctly determining that the medication was safe in the group with the explicit safety warning versus the group with the basic age information. And there was no difference in the group that received the explicit warning with the pictogram versus the group that received the explicit warning without the pictogram. The takeaway point from this is that labeling changes can improve parent understanding of age restriction information. In conclusion, there are many sources of existing confusion for parents when they use medications, whether from formulations, concentrations, active ingredients, dosing, or age restrictions. If we change product characteristics, health literacy-informed approaches should be considered to support parent understanding and ability to act on medication changes, including through education and counseling and improved labeling. There will be a need for extensive consumer testing, especially with those with low health literacy, as well as public health campaigning. Thank you.
Thank you, Shonna. So our next speaker is Dr. Russell Bradford. He is a pediatric infectious disease specialist and hospitalist who is the Senior Vice President at PEGAS Research, a contract research organization conducting consumer behavior research. Welcome, Dr. Bradford.
Thank you. Good afternoon. I appreciate the opportunity to be here and the invitation to participate in the workshop today. This topic is one that it represents the confluence of a couple of main thrusts of my career. So, first of all, addressing the needs of the pediatric patient population, and then second, how consumer behavior research is used in the development of non-prescription products. And I really appreciate Dr. Yin's presentation because it introduces many of the concepts of consumer behavior research, though done in a slightly different focus than the kinds of research that we typically do. So let's answer the question that might be top of your mind now, which is, who's this guy and why is he standing up here talking to me, especially at the end of a long day like this? Like many of those who have spoken already today, I'm a pediatrician. I've been practicing hospital-based pediatrics for in one capacity or another for about 25 years, and I run the Pediatric Hospitalist program at the Community Hospital in Park City, Utah. And I'm also the Senior Vice President at Pegasus Research. We're a contract research organization that specializes in consumer behavior research of all sorts, but primarily in the non-prescription space, and particularly involving products that consumer healthcare companies are interested in switching from prescription to over-the-counter status. In fact, as an aside, the very first study we ran as a company, which was about 33 years ago when I was an undergrad research assistant, was the Children's Analgesic Medicine Project, or CAMP study, which compared the safety of acetaminophen suspension with ibuprofen suspension in about 42,000 children, and was a key part of the effort to make children's Advil available over the counter. So that leads me to my disclosures. I work for Pegasus Research. That's who pays me, but Pegasus Research is contracted by many different sponsor companies, and we provide consulting and conduct consumer behavior research. But while I have interactions with teams at those sponsor companies, I don't have any direct relationship, financial or otherwise, with those companies. And now I'll just mention another disclosure that is a disclosure of a different sort. We've talked a lot about some actual products that are available on the market, particularly acetaminophen and ibuprofen. But I'm going to talk today about a fictional product that has a hypothetical ingredient, and I'm doing that in order to sort of better illustrate some key principles. So with that, I want to introduce you to Duplanol. So Duplanol is a product that where the manufacturer is very excited. They feel like it has the potential to fill a need for a more effective analgesic that's targeted to the 2 to 12-year-old children, and it has some interesting characteristics. And I'll show you why they are so excited. So first of all, it's an oral suspension pain reliever, familiar to all of us. It's a combination product, but in a couple of different senses. First of all, it's a fixed combination product with 2 active ingredients, the first of which is acetaminophen. This has been formulated in a proprietary process that makes it longer acting, so it has some delayed release characteristics. And it's paired with the second active ingredient, novelprofen, which is a new NSAID with a relatively longer half-life. So in their clinical trials, the companies demonstrated that novelprofen is safe and effective when used as directed, and they've found that it's more effective than the existing OTC NSAIDs for pain. But however, like ibuprofen and naproxen, it should not be used concomitantly with other NSAIDs. And while it's safe for use for up to 5 days, using it longer than 5 days consecutively leads to an increase in adverse events. So there's a labeled warning and not to use for more than 5 consecutive days. And while novelprofen, like other NSAIDs, is an effective antipyretic, during their early developmental studies, the company found that there was a safety signal suggesting some rare but serious complications in children with active bacterial infections. So as a result, the product is labeled for relief of pain, but should not be used for fever. One feature that the company is excited about is the dosing interval, which is every 8 to 12 hours, less frequently than other non-prescription analgesics for this age group. And we've heard over and over today, I think, about how this might be a benefit. And finally, I mentioned that this is a combination product in another sense. And a creative team at the company has devised a dosing device that they intend to supply with Duplanol. The suspension bottle and this dosing device are intended to work together to deliver the right individualized dose for each child. And the device allows the caregiver to dial in the child's weight or age and then dock the device with the suspension bottle to draw up the appropriate dose. And they're excited about this because they feel that this will reduce both underdosing and overdosing and lead to better outcomes. So you can see that there are certainly some intriguing features of this product, and you can understand why those at the company might be enthusiastic about it. However, some of these features also raise some significant questions and concerns, and I'm sure you've been compiling them in your head as we've gone along. And in fact, the company just had their first interaction with the Division of Non-Prescription Drugs, and during that interaction, they got some advice from Dr. Todd and her team about the features of Duplainol that raise some concerns. So first of all, do consumers recognize that there are multiple active ingredients in this product? It contains acetaminophen, and so do consumers understand what that means? Do they recognize that it shouldn't be given with other acetaminophen-containing products? We've heard that theme echoed today. It also contains novelprofen, which should not be given with other NSAID-containing products. So do consumers understand that concept? Do they recognize what those other products are? Do they understand that class of medication? This medication shouldn't be used as an antipyretic, and that's different from other common pediatric OTC analgesics, which are all also used for fever. And so can consumers navigate and negotiate that difference? And then can caregivers recognize that it shouldn't be used for more than 5 days, and will they actually follow that guidance? Do consumers understand the dosing interval, particularly in light of the fact that it differs with other common OTC products for this age group? And then finally, can consumers use this new dosing device that the company's come up with? Do they understand the instructions for use? Do they know the correct inputs for the device? For example, can they actually accurately recall or come up with their child's weight? Can they perform the steps that are needed to lead up to drawing up an accurate dose and administering it correctly? So this represents a considerable list of potential issues. Many of them are introduced by differences between Duplainol and other available products. And layered over the top of all of these is the caregiver and child dynamic. Certainly for most children, ages 2 to 12, the caregiver is the consumer that we're talking about, whose comprehension and behavior we're concerned with, because they're the one that's responsible for choosing and administering the medication. But there may be some children at the upper end of that age group that could take a more prominent role in their own medication administration. And so their comprehension and behavior at least needs to be considered as well. So how then do we begin to generate some data that helps us address some of these concerns? I'm going to give you a little bit of background by describing 5 of the most common consumer behavior studies that are used in drug development in industry. The first is a non-clinical study known as a label comprehension study. The goal of label comprehension studies are to assess how well each of the key messages from the product labeling, particularly the drug facts label, are understood by typical consumers. And a research program for a non-prescription product, especially one with new labeling, might require some iterative testing of the label with revisions that are driven by the learnings that come from each study. Next are label discernment studies. These are a little less commonly done, but they tend to be focused in situations that are like this one because they evaluate whether product labeling is effective in communicating the important differences between the new product and other existing products that could be a source of confusion. These two types of studies are typically done in a general population sample. Does the population as a whole understand the labeling? Because we can't predict necessarily who might need to review the labeling and understand it. The next, on the other hand, self-selection studies tend to be focused in those who have a potential interest in using the product. And the goal of self-selection study is to assess whether those who should not use the product can appropriately recognize that and then correctly identify that the product's not okay for them to use, all while guided only by the drug facts label and other product labeling and without the guidance of a learned intermediary like a healthcare professional. The next type of consumer behavior study are human factor studies. These assess how well consumers can use devices that either themselves are the product or that constitute a key component of the product. And then finally, actual use studies are observational clinical trials that simulate the non-prescription environment and measure use behaviors of interest among participants. So with that bit of background, let's look again back at the issues that are raised by the characteristics of Duplanol with an eye toward how those issues might be addressed by consumer behavior studies. So then, how can we evaluate whether consumers recognize that this product contains two active ingredients? Well, we're likely to need a combination of label comprehension studies where we assess understanding of individual labeling messages, and label discernment studies where we assess whether consumers can understand how this product differs from other similar products. Similarly, the concern about concomitant use of other acetaminophen products or other NSAIDs are likely to both require label comprehension and label discernment studies. And while the concomitant use concern might not on its own be the primary focus of an actual use study, you could envision that if an actual use study is otherwise necessary, that might be a good opportunity to observe concomitant use in actual users in the simulated OTC environment. Well, what about the instruction not to use for fever because of concern about those with active bacterial infections? In addition to label comprehension studies, self-selection study is probably the best suited for evaluating whether consumers can recognize and correctly apply this warning to themselves or their child. Again, if an actual use study were needed as well, that might also generate some additional supportive evidence related to how well this warning is adhered to. And while the warning about not using the product for more than 5 days can and should be assessed for comprehension, like all of these other warnings, for warnings like this one, observing adherence with the warning in an actual use study provides the most robust evidence for what consumers might actually do were the product to be available in the non-prescription market. Similarly, while assessing comprehension of the dosing interval messaging is important, observing how the product is actually used in the simulated OTC environment of an actual use study is the proof in the pudding, as it were. And then finally, let's talk about the dial-a-dose dosing device. You can imagine how a well-designed and executed device might enhance safety and effectiveness of a product like this, but only if consumers can use it correctly. And so in cases of situations like this, the human factor study model is the best one to evaluate these kinds of consumer behaviors because it helps outline the ways in which consumers interface with devices, and it helps identify the ways that they might fail in their use of a device, and helps us understand the consequences of those potential failures. So it appears that the company has a fair amount of work to do as they move this Duplanol program forward. And while this illustration has been fictional, I hope it's been a useful illustration about the kinds of issues that new products might raise and the possible strategies for addressing those concerns in a development program. So once again, I appreciate the opportunity to participate today, and certainly, especially if I've raised more questions for you than provided answers, please feel free to reach out at any time.
Thank you, Dr. Bradford, and to all of our speakers for session 2. Appreciate the informative presentations. Before we begin our second panel session, we will have a 10-minute break. So similar to last time, if all of the panelists can be seated at the table before 2:40, we'll get started with our panel at that time. Thank you. We'll see you back for 2:40.
Hi, everyone. Welcome to the panel discussion for session 2. My name is Mona Karana. I'm a team leader in the Division of Pediatrics and Maternal Health.
Hi, and my name is Dorothy Chang. I'm the Deputy Director for Safety in the Division of Non-Prescription Drugs 1.
Dorothy and I are going to be co-moderating this part of the session. So our speakers from session 2 are joined on the panel by Casey Cashman and Diane Hinman, who had participated in session 1. We also have an additional panelist, Rout Reigert, who has not yet been introduced. So I just wanted to take a moment and ask Rout to perhaps briefly introduce yourself before we get started.
Okay, I'm Rout Reigert. I'm a general pediatrician. I'm also chair of the Committee on Drugs at the American Academy of Pediatrics. And I could take just 1 second. The Committee on Drugs is a relatively small group with a lot of affiliates, including FDA. But we also have another companion group at the Academy of Pediatrics known as the Section on Clinical Pharmacy and Therapeutics. And both of these groups are very interested in drugs. And I was really sort of, gratified to hear all the sites for healthychildren.org, which is a part of the American Academy of Pediatrics. And the Committee on Drugs right now is in the process of reviewing all the Healthy Children sites that have to do with drug or drug administration to revise it. And Diane, I think, has chosen one of the topics to revise, as has the rest of us. And we would welcome anyone who ever looks at healthychildren.org to identify any sections that they think need updating to help us in the systematic review. But we have 2 very active groups, the Committee on Drugs and the Section on Clinical Pharmacology and Therapeutics. And we're both ready and able to help anyone that has an interest in drugs and children and how they're administered and all the stuff we're talking about here. So I'm glad I was invited to participate. And I'm quick to mention that I nominated Diane to be one of the speakers. It was sort of a draft, and she did a great job for the Academy. Thank you.
Thanks very much, Rout. We also have another panelist who's joining us virtually. His name is Jonathan Zapersky. And Jonathan, could you unmute and perhaps introduce yourself as well?
Sure. Hi there. Sorry for showing up late. I'm John Zapersky. I'm a clinical pharmacologist and toxicologist at the University of Toronto, and a health services researcher at Sunnybrook Health Sciences Center in Toronto. And I mainly do research on adverse drug events, so in children as well.
Thanks very much, Jonathan. As we begin this session and panel discussion, we do ask our panelists to please speak directly into the mic. And those in the back who can't hear, please do let us know.
Okay, thank you very much. So before we begin, we thought we should take a moment to set the stage and get folks in the right frame of mind for this second panel session. And as we've already heard, the first session was intended to really explore the potential benefits of additional acetaminophen and/or NSAID non-prescription products for the 2 to 12-year age group. And the purpose of the second session is to discuss the potential consequences of deviating from one or more of the existing product characteristics of currently approved products in the space. So in the slide being shown, we hope to remind everyone of these characteristics. Recall from my colleague's presentation at the start of the day that the current products are all immediate release formulations, use well-established dosing intervals, are dual labeled for both pain relief and fever reduction, contain either acetaminophen or ibuprofen, and come in well-established dosage forms. And we plan to walk through each of these characteristics in the following discussions. As we've heard during the preceding presentations, the currently available products have a long history of consumer use in the non-prescription pediatric context. And though there have been a number of lessons learned along the way, we believe consumers are currently in a place where the existing products have a reasonably well-established safety profile and familiarity. So going forward, as we contemplate potential introduction of additional products to the non-prescription space, we would like to hear from our expert panel which differences may result in potential consequences when consumers administer these products to their children without any medical oversight. And we also want to hear if these are issues that can be reasonably mitigated through labeling, and if consumer understanding of the labeling can be reasonably assessed through consumer studies. So with that in mind, let's launch into our first question. So the currently approved products have well-established immediate release profiles and well-established dosing intervals. Can we start with addressing whether this panel believes that introducing additional products in the non-prescription setting that require the products to be given more or less frequently could lead to medication errors? And if so, what do you think might be the source of the confusion?
I guess I can start. I think that it would be silly for us to think that there would be no consequences and that there would be no errors, period. But do those errors outweigh the benefits that could come from those medications as well? And I think that's what we need to look at, and then really focus on proper labeling and labeling for the actual consumer so that they can understand that labeling and all of the words on the box. It's not all doctor language, and it's more actual patient and or caregiver language. And then just the proper education that would come from us making sure everybody understands the differences behind these medications. But I think you have to realize there will be those situations, but I think that the benefits would definitely outweigh that.
Yeah, I would agree with Casey as well. I mean, it's almost like we know the answer to the problem that could happen because we've been talking about it, the education piece. So we sort of solved it. I mean, again, there's going to be different types of medications and different delivery systems and platforms that might make some changes in there. But we talk about we need to provide those people who are giving those medications the education that they need, whatever the type of medication is. So it's very clear. But again, we know the answer. So we just have to, implement those answers that we already have established.
We've heard pretty consistently in session one about the utility of having longer acting medications in the non-prescription space here for this age group. So, when we ask this question, the more realistic scenario would be what types of medication errors might there be with introduction of longer acting ibuprofen or acetaminophen products. And education could certainly be should be one piece of that, and raising awareness. And I'm looking to Russ and I'm looking to Shonna, and I'm trying to think what types of med errors, and maybe even before we get to you, what might be a consequence if a family or a consumer is accustomed to dosing ibuprofen every 6 hours and is now taking a longer-acting ibuprofen. What should we be thinking about in a pre-market setting that we should be studying that we could perhaps then use to enhance the drug facts label, packaging, et cetera?
I think one nice thing about the problem in this patient population and with this class of medicines at least is one that I think Kate made pretty well, which is that fortunately the products themselves have a fairly wide they're fairly forgiving in terms of errors, and the patients are pretty forgiving when it comes to errors, and so that shouldn't make us cavalier about it, but it should, I think from a clinical standpoint at least, it allows us to contextualize the errors that we might see. I think Shonna did a great job demonstrating how effective labeling can make a big difference in the comprehension and adherence to the labeled directions, and I think that is one of the things we should take away from this is that there are always opportunities to optimize labeling in a way that allow us to sort of improve at the margins those places where errors might occur. We're never going to get to perfection, probably with any product in any situation. But if we can make some gains in adherence to those instructions, I think we will be doing the public a service.
So I agree that the safety margins are for acetaminophen and ibuprofen are pretty good, so there's less worry about the clinical implications. However, I do think that it's important for people to be taking the medications as they're directed, and I think labeling can help, as I mentioned earlier. For the adult acetaminophen and ibuprofen extended versions, they do really prominently label the frequency on the packaging, almost as large as the brand name. And so just thinking about emphasizing the frequency, thinking about emphasizing that it's extended release, and in contrast to the immediate release, could be very helpful from a labeling standpoint.
I would just add that while both acetaminophen and ibuprofen are very safe now, at one point, many children were being injured by pediatric acetaminophen, particularly the infant's concentration. I reviewed many cases of children who died because they received repeated supertherapeutic ingestion. So keeping in mind that whatever new dosage formulations that are introduced, we need to make sure it's very hard for a parent to give way too much over a longer period of time, even with whatever changes resulted.
I was just going to add, especially with the success we've seen in having a standardized acetaminophen concentration, hopefully keeping concentrations or dosage amounts in a comparable way, so we're not adding some totally new, now it's going to be 55.5 milligrams per 2 mils or something crazy, which would potentially make it more difficult for parents to do the right thing and give the right dose.
Thank you. Go ahead.
I also think, though, an extended release or long-acting, that's not new. I mean, it's new to the pediatric space, but it's not new to the consumer. So that parent has already has that knowledge that this is going to last longer than just the regular acetaminophen immediate release one. And so if it would come down to making sure that it is very, predominant on the label, on the box, and on the bottle itself, to make sure people understand that. And then when we're talking about education, does it make sense to have like a QR code almost on the bottle that a parent could scan that QR code and it would take them to an app that it would say, okay, I'm taking extended release acetaminophen, whatever, and this is how much I took at this time, and then you know, when they would go to take another dose of another medication, whether it was the same medication or a different one, it could alert them to say, nope, this is the same active ingredient as what you already took, you know, like, so can we make it simplified for that parent as well? Something along those lines. But I think that the extended release is not new to this space, to the pediatric space it is, but the parent already knows that it's going to last longer already.
So what I'm hearing, and it seems to me a consensus, and please let me know if you disagree, is that the concern for med errors that could potentially be introduced, it seems as though from the panel, it could be mitigated with labeling and education. I guess the one follow-up question is, do you think the labeling changes and education alone are sufficient, or is there any value in any consumer use study pre-market to help with those labeling enhancements? Or is it, you know, is it hard to answer that in a broad sense, and is that something we'd have to think about on a case-by-case basis?
From my perspective, I think you would insist on pre-market studies to demonstrate that. You know, I think right now we're speculating what the magnitude of the problem might be for a change in dosing and interval or whatever. But we can at least get some very good directional data about the magnitude of that problem by conducting studies like the ones that Shonna and I both spent time talking about today, and so I think you'd be compelled to demonstrate that while we believe that this can be mitigated, you know, are we talking about mitigating a problem of 10% of people understanding to now 20% of people understanding? That might still raise some significant concerns, I would imagine, from a regulator's perspective.
Thank you for that response. To follow on, can you elaborate if you view an adult product versus a pediatric product differently, and would you expect specific studies in the pediatric population in that same vein?
Yeah, I think I would, at least in the 2 to 12-year-old population, where you would expect that the consumer, again, is the parent or the caregiver. There's certainly something to be learned from the experience of comprehension and behavior for the entire adult population. But I certainly would be interested in understanding how those play out among caregivers. I think it's a trickier question, at least in this age group, to ask the question about comprehension and behavior for the actual patient, the child, because by and large, these are not consumers in the standard sense of things. They're not going out to purchase product, and while they might get given some leeway in administering their own dose, they're probably not choosing a medicine and so on.
Go ahead, Diane, and then Jonathan.
I was going to add as well, to my knowledge, there haven't been any great studies that suggested extended release or long-acting products really do improve compliance. So I think that even though theoretically we assume that they probably should improve compliance, so I think you would need to evaluate efficacy from a compliance perspective as well with such products. Because although I'm more concerned about the safety of such products, if we're doing extended release products because parents are asking for something that lasts longer, if they're still not giving it, if they're only giving it once a day instead of 3 times a day, it's still not going to be effective if they don't give it according to the dosing recommendations.
Thanks, Diane. Jonathan?
Sure, can you hear me okay?
Yes.
So I just, I wanted to provide a slightly different perspective. I'm in Toronto, and just a bit of a historical word of caution is that back in the end of 2022, we had a shortfall of pediatric drugs in Canada. We weren't able to stock acetaminophen and ibuprofen primarily. This occurred for about 6 months, from about August to the end of 2022. And we did some work to characterize what happened during that period. And some of our poison centers and hospitals gave out some recommendations about how to modify adult doses to pediatric doses. And suffice to say, that didn't work out so well. We had an increase, we studied this and had an increase in calls to our regional poison center for non-severe pediatric overdoses of Tylenol and ibuprofen. So just a word of caution that anytime, this doesn't have to do with, delayed release formulations, but anytime people are used to a certain formulation of a drug or certain dosing, and we change that up, there is likely to be some impact on knowledge and understanding and potential risk to patients. And whether this, I can say, I don't think there was a significant risk to the patients in terms of, like, we didn't see increases in hospitalizations associated with poisonings, but I think almost just a word of caution that anytime you're changing up the dosing interval or dose or formulation, it is possible that there may be some risks to the patient population.
Thanks very much for sharing that important perspective. Yeah, go ahead, Ralph.
Yeah, it occurs to me that we've talked about everything except the physicians. And when you make a change in available drugs, even if they're over the counter, it often takes a long time to educate physicians about how to do it properly and how they should educate their patients to use it properly and monitor that it's being used properly. You all saw referenced the Academy of Pediatrics statement on control of fever. I talk to a lot of pediatricians that don't follow those guidelines and advising their families about how to use ibuprofen and acetaminophen in advising families. So I think it's an important issue that as you introduce new drugs, new formulations, that we do a good job of making sure physicians are doing their job at advising their families on how properly to use it, and then monitoring to make sure they're doing it, particularly with over-the-counter, because the family can just go grab it, and if you don't know what they're doing, you could have problems.
Thank you. Diane?
To add on to Ralph's comment, from a toxicology perspective as well, the Rumac nomogram, for example, with acetaminophen overdoses is well known in the standard that we use to determine whether patients need to receive antidote. But if you're giving an extended release acetaminophen and you don't have any idea what dosage product the person took, then that becomes a further challenge that needs to be considered.
Thanks very much, everyone, as we just wrap up this first question. I just had one final question. It sounds as though at a minimum, and again, I'm looking to you, Russ, a minimum label comp, perhaps label discernment at a minimum, it sounds like. Is that right?
Certainly. I think let's envision a product that is simply an extended release version of acetaminophen or ibuprofen, so products that are already on the market. I think you'd certainly want to understand how well people comprehend the associated labeling, and you'd certainly want to gather some data to understand the degree to which they might confuse the new product with existing products. So label comp and label discernment. Unlikely to be additional self-selection issues that are raised by this product, and I think it would be hard to justify the expense and sort of issues around an actual use study for a product like this. But I guess it would depend on the specifics of the product. But certainly at a minimum, label comprehension.
Thanks very much. Let's move on to the next question for the sake of time.
So the second question is related to introducing products, again, in that same vein of products that differ in the immediate release formulation or profile. Is there any concern of this panel that this may lead to masked symptoms of more serious pain or fever conditions and potentially delay a timely diagnosis of that condition?
Sorry, it was hard to hear you down here. Was it that, if it is an extended release, are we masking the symptoms? Is that the question?
Correct. The concern is there any concern about a delay in diagnosis because of a mask condition?
Okay.
Yep.
I mean, from the consumer's perspective, is most of these individuals can't get into the doctor's appointment even, in a day or two. Most of them, are going to, it's going to take them a couple days to even get in to an appointment. And so, I mean, I think like on any of these medications, it says, you shouldn't take longer than X number of days. And so as long as those rules and guidelines are on there, I don't think that's really masking over anything as much as we are just helping to hopefully put that patient, the child, into comfort at least for those couple days, maybe while they're waiting to get into a doctor's appointment or waiting to get into a specialist or something along those lines. But if it's over a certain number of days, it should still say you must consult your physician at that point.
Thanks so much. I think Ian Paul in his talk in session 1 had alluded to the fact that when taken as labeled, and I can't remember if he had data that supported this, but really didn't have much concern from a clinical standpoint that taking ibuprofen or acetaminophen as labeled would mask something more serious, at least from a non-prescription standpoint. Just wondering if the clinicians on the panel have thoughts on that, whether they concur with that.
I wouldn't be concerned about it masking something.
Diane, could you speak in? Thank you.
I wouldn't be concerned about it masking a more serious febrile or painful condition just because it might be a longer acting or a combination product if it's used appropriately according to the instructions. Where it might be more of a concern would be if they're taking more drug, whether it's an extended release product and they're taking it every 4 hours instead of every 8 or every 12 hours, it could mask a toxicity, especially with acetaminophen. But from the serious nature of a febrile or painful condition, I wouldn't have a concern.
Thanks, Diane. Brout, Jonathan?
Yeah, I have a slightly different thought about this. I think I'm the only person in the room that's treated a lot of patients with Rye syndrome, because I'm that old. And it was first recognized in 1963 and then became quite common through the 70s and early 80s when all we had was aspirin. Ibuprofen was not available. And so I'm thinking that we're starting to use what we thought were safe drugs in different ways. Would we miss a cue? It's hard to figure out. We've been using aspirin for 100 years when all of a sudden we had this new disease that was killing kids every day. So I think the surveillance when you make a change like this is very important to make sure that there's not some inadvertent event that may have very subtle cues. It's hard to figure out that salicylates had something to do with Rye syndrome.
Thank you. Russ, are you going to speak?
Yeah, I wholeheartedly agree about wanting to keep an eye on things, in terms of surveillance. But the comment I was going to make from a clinician standpoint is that one of our best tools in pediatrics is benign neglect. Letting kids get better because they're going to get better, and in fact, it's a tool that all clinicians use, regardless of age of their patient. And so the idea that by having a more effective or a better selection of products to treat symptoms somehow leads to worse outcomes. I understand where that comes from, but I think that in reality, what I would do as a clinician in most cases is treat conservatively and see what happens. And so it's a reasonable thing to expect that parents might do that and in fact they do that as their first line of treatment in most cases. We certainly wouldn't be in a position as a medical system to see every kid that has fever or every kid that has pain. And so to my thinking, as a clinician at least, the idea that just because you can dose it, every 8 hours instead of every 6 hours, as introducing significant concerns from a standpoint of masking serious illness, I think that's a concern that's not likely to play out.
Thank you. And I just want to give Jonathan and Petrea an opportunity to weigh in if you want. Anything you want to add to what's already been said? No. Okay, great. Oh, go ahead, Jonathan.
No, I was just going to say, no, I agree with what's been said on the panel thus far regarding that, regarding this question.
Same for myself as well.
Excellent, thank you.
All right. Moving on to our next question related to fixed dose combination products. So in considering a potential product that combines acetaminophen with an NSAID, and also considering the common practice and sometimes recommendations from physicians to alternate between acetaminophen and NSAIDs, are there potential safety concerns with products that combine these ingredients that we should think about addressing pre-market? Sorry, can you hear if I speak this close? So I'm talking about the topic of a fixed dose combination product and considering the common practice and recommendations from some patients to alternate between acetaminophen and NSAIDs. Are there potential safety concerns from this group with products that combine these ingredients that should be addressed pre-market?
So I would say as a pharmacist, there's definitely been a proven history of having issues with combination products. I'm not saying that I don't think it wouldn't be a good idea or that we shouldn't explore it. It just needs extensive education because we know in the past that people will use additional products. I believe it was mentioned this morning, if something's labeled for pain and then something's labeled for fever, I can see someone take both products because they have a pain and a fever. So I could see them taking a combination product and one of these other products because they've always taken that product before.
Thanks, Petrea. I think one of the things we often grapple with is the limited dosing flexibility that we're capable of with a fixed dose combination. Particularly across a broad pediatric age range, such as this one, where the weights could be, span, tens of kilograms. And so I guess on the one hand, how practical might it be to develop a fixed dose combination for this age group? And then if one were to develop that, kind of balancing that with what we've heard earlier in this session about the effective efforts that have been implemented to standardize concentrations of the single ingredients and how that might get impacted with introduction of fixed dose combinations. Please, go ahead.
One thing I'd add to that is I could see, as a pediatric pharmacist, sometimes what we'll see in practice done is they'll use a combination product and then be like, oh, I'd like to add a little bit more of this because I know I can push that dose a little bit more. I think that there might be some people or individuals that might try that, and that will then be very confusing to the provider because the acetaminophen and ibuprofen dosing intervals overlap, but they have different ranges. So I could see this definitely being a concern.
Thanks, Petrea. Go ahead, Diane.
I was going to say, if we look at the Italian product that is 3.3 to 1 milligram, acetaminophen versus ibuprofen, and if we look at the American adult product, which is 1 to 1, or sorry, 2 to 1, 250 to 125 for the tablets, it's hard for me to think about there being a problem. But if you look at 160 and 100, we're kind of dosing 160 times 15 and 100 times 10 milligrams per kilo to get a comparable dose for a child at this point. It would be interesting to me to see how we decide what the actual ratios would be, whether we would use something comparable. If it was a liquid that had both products, as an example, would it be something comparable as just adding ibuprofen and acetaminophen together and dosing it the same way we kind of do at this point, or whether we would go to something like what Italy has done or what the adult product is. And I don't know that we have a good understanding of whether the same doses for acetaminophen and ibuprofen in the same product would give a better effect, and hence we should use similar doses, or whether we should use less doses to get the same effect. And I don't think we really understand that at this point, so that would be something that I think would be important to research.
Wade, please, go ahead.
Yeah, and I was just going to add to what I had said during my presentation. So one of the major children's hospitals I was referring to, they don't use combination medications. They're not necessarily against using them if they're the right formulation, but they alternate. And what that allows them to do is to provide or to determine which one is working and maybe giving a little bit more of another, but also making sure, especially in the space of pain management, that one of them's not wearing off and then pain is increasing. So again, what Diane was talking about with this Italian study, that sounds promising. It does. It really sounds like an interesting thing, because if we can make a determination that these two combinations are potentially wearing off at the same time, but also providing the proper dose at the same time, maybe it has benefits.
I think that going along with all of this is that, mind you, I might be the only non-doctor up here, so sorry for that. But that from a consumer's perspective is that every medication is not all the same, right? So when you guys sit here and say, well, milliliters to kilos, well, I don't know what I weigh in a kilo, right? And so from that parent's perspective, if that's what we're going to be thinking about, that parent at 2 a.m. in the morning who's in that doctor's office, well, they don't know the kilos part. So putting it into, for us here in the United States is in pounds, and then having it so that some of them are age-based and some of them are weight-based. But then I think I was reading on one of the slides that it was like up to 92 or 95 pounds and 12 years old. But I mean, if I have a 9-year-old who's weighing 100 pounds, does that mean then that I can give them the adult strength because they're now over that weight? Or does that mean, can I give them a little bit more? Like what does that mean then if they're over that weight but under that age? And so just having more uniformity across all of those, I think would truly help the patient, and the caregiver, to understand and have it all be the same between the different medications.
Thank you. I'm looking again to Russ and Shonna, and I'm going to ask you, let's say we consider, right, a different strength, just to allow the development of a fixed-dose combination. Going back to, again, thinking about education, labeling, consumer use, at a minimum, what would we want to understand in a pre-market setting from consumer use studies?
Well, I think I'll give you two responses there. First is from a clinician's perspective. I take care of a lot of kids who have just had orthopedic surgery, and so I do a lot of education with families about managing pain in a post-operative setting. many of these are kids who've just had scoliosis surgery, so it's a big procedure, a lot of pain. They're going to be on medicine for a long time. And from that perspective, I don't have any clinical concern about a patient taking the full dose for their weight of ibuprofen together with the full dose of acetaminophen for their weight. So clinically, I use that all the time. I don't have any data that would inform me whether or not, because I'm using them together, I could maybe back off on one or another of those doses. And I think that's important to know, but I'm not concerned about it. And in fact, in many cases, I'm needing more pain control than what I'm able to provide with just those two medicines. So often I would push those to their maximum doses anyway in that setting. Could you develop a fixed dose combination that is 1.5 to 1, or the sort of per kilo dose per kilo ratio that we do for acetaminophen, 15 per kilo and 10 per kilo of ibuprofen, and would a product like that simplify for families the process of administering medicine in an effective way, and would it make it safer? My suspicion is that it would, but I don't have a lot of data to back that up. Other than that, we use the strategy in clinical practice all the time. It's just in two different bottles, and for me, that has the potential to add some concern. I typically advise patients to alternate, like many do, but I don't have any data there either that helps me understand whether administering them together at the same time is any less efficacious than the alternating strategy. And I'm not aware of any data except for the data that Ian showed this morning that for fever that might suggest that administering together is just as good as the alternating strategy, in which case simplifying things for a family is a great thing. These are often, at least my patients, are those going home on multiple medications, and so if I can simplify it for them, I'm thrilled to be able to do that. But the secondary question was about sort of what would you need to know pre-market in order to be comfortable moving forward with that, and I think from my standpoint, again, I would be very interested if a sponsor organization were to generate some clinical data to suggest whether there's a more effective or more appropriate dose combination. But I wouldn't necessarily be concerned about it should they go forward with sort of a full dose strategy.
I was wondering, so if a fixed dose combination allowed a lower dose of one or both actives, right? Now we're introducing some different strengths potentially into the non-prescription space. And so, we've heard from different folks earlier in this workshop that could introduce medication errors potentially. And so the thought would be, how could you mitigate that?
Yeah, I guess from a clinical standpoint, my point is, I think it would be lovely if we had the data to suggest that we could back off on a dose so as to limit exposure. I'm not aware of any data that exists to inform that, and I would love to have that. But on the other hand, I'm not concerned from a exposure standpoint, even if it went at the full dose strategy.
Thank you so much.
I can imagine it could be confusing, though, if there were, lower concentrations for the different medications in the combination version. And I can imagine that maybe some savvier parents, if they feel like the pain's not controlled, might try to compensate for that difference, that they think that is present. So I could see how there could be confusion if there's a different formulation.
And I'd have the same concern. I think it would be nice to be able to provide lots of options, but with that in mind, I would be more concerned about the the addition of products to achieve, effect or something like that in a savvy parent who might have a general concept but not understand completely.
Go ahead, Wayne.
I was going to say, I agree with both of them. That makes perfect sense, because we always hear about, don't give more medication than's needed. So whether a savvy parent or a semi-savvy parent, I could see them going, well, I'm going to give you this little bit, and if you need more, I can give it to you sooner. And I can give you more and keep, elevating and escalating it right back up. So I agree.
I would just add that there must have been some decision when the adult formulation was approved in this country, and is there any research or any literature evidence that we can get from that? Because 250 of acetaminophen and 150 of ibuprofen seems like less than what we would typically give in an adult situation. So the assumption must have been that there was a synergistic effect rather than, or I don't know whether it was synergistic or just additive, but maybe we could look to how that was derived and make a determination along with all these other concerns.
Thanks, everyone.
I was just saying that the adult product in the U.S. has 250 milligrams of acetaminophen and 150 milligrams of ibuprofen, which is technically less per dose of medicine than we would typically give to an adult. So perhaps when it was decided that that would be the combination, there was evidence that played into that decision, and we could look at that to help to decide whether we needed the same doses, lower doses, whether there was an additive effect or a synergistic effect by combining the product.
And if so, is that hold true among the pediatric population, which is, I think, one of our concerns?
Yes, these are all very interesting topics. I think some of it may kind of get into product-specific information that we aren't able to discuss today. I do want to continue moving along with our questions, and our next topic is related to dual labeling for the indications of pain relief and fever reduction. Currently, as you know, all the products for this age group are labeled for both pain reduction and fever relief. And does this panel believe that introducing additional ibuprofen or acetaminophen products that are labeled for only one of these indications rather than both could lead to medication errors or serious safety concerns? Anyone, any takers for that question? Oh, really? It sounded so loud in my head. So the topic is related to dual labeling for pain relief and fever reduction. So currently, all products are labeled for both. And so the question is, does this panel have any concerns if a product is only labeled for one or the other and not both? And do you believe that it may lead to medication errors, or what serious safety concerns might you have?
I think yes. I think that the answer would be people would probably misuse them because somebody would think this would just be for pain and this would just be for fever. And if it is the exact same medication that, they potentially could, the fever might then be gone, but now the kid's in pain. So now the parent is thinking, all right, well, this was for the fever, so now I'm going to give them this for the pain. But then the other thing is again, that 2 a.m. parent who went down to their medicine cabinet and all they have is the fever medication, but really the kid's has ear pain, and they're like, well, we can't give them this because it's not for the pain. But again, it was the same medication, so then are they not giving the kid the medication that they really do need? So I think it can go both ways, but I definitely think that if it's the same medication for pain and the same medication for fever, that it would lead to consumers inadvertently, misdosing their child because they're going to think, I've treated one and not the other, and then I'm going to treat the other one thinking it's two different medications.
Thank you. Diane?
I think also it's important to remember that many of the times when kids need these medicines, they have pain and fever together, which adds another dimension to the problem that we're discussing.
Yeah, I echo the concerns that were expressed this morning as well, and I think it really, you could certainly envision a product that should only be used for either pain or fever for some reason, but it doesn't make any sense to me for a product that can be used for either pain or fever to label them separately. If they can, if the dose is the same and the use is the same, I think it would be a mistake to try and differentiate that simply for the effect of maybe enhancing sales or whatever it was for that indication. But that for me raises the question: what about that product that comes along that falls into this space that for one reason or another shouldn't be used for fever or shouldn't be used for pain, and it's a little hard to without specifics of a product like that, it's a little hard to address. But certainly for the products that we have available, I also would be very cautious about labeling for only one indication.
Thank you. I think we have time for one last question, so we'll go ahead with
Okay, so can you hear me? So all of the current OTC pain and fever medications marketed to this age group contain either acetaminophen or ibuprofen. Do folks on the panel think that introducing an additional NSAID ingredient, such as perhaps naproxen, could lead to medication errors and serious safety concerns? Do consumers understand, that naproxen is an NSAID, as is ibuprofen, et cetera? And what do you think about that potential issue?
I guess I'll start again. And I think it's the same as I was saying before, as with the extended release, is that NSAIDs are not something new to this consumer group. The adults have had NSAIDs now for forever, and so they already know of that group, and so they know the difference between, well, I don't want to say they know the difference, because I don't know that all of us, the consumers, know the difference between acetaminophen and naproxen and things like that. But I think that also just comes down to the education to say, well, this is what you would use this for, this is what you would use this for, and this is what you would use this for. But again, it's not a new medication coming in that the consumers have no idea. They've never heard of this before. They already have the understanding, but just the education from the parents' perspective.
Yeah, I would say the same thing. I mean, but also to make sure that they know what the active ingredient is, so they can see that across the realm there. But it really is. It kind of comes down to the education. If you're going to introduce anything into the market, you don't want people to make it a guess of what it does. We're going to guess what this does this probably, or this is a new thing. We've got to try it. But finding out it's actually the same thing that you've been using in a little bit of a different formulation. So really, education is the key. I think that's really the sort of one of the major concepts that's coming out of this great workshop for individuals and the caregivers, is just we need to get them more education.
Thank you. I'm going to again look at Russ and Shonna.
I feel like I've talked a lot today. I don't want to overexpress, but I think I agree that I think one of the reasons that we are hesitant when it comes to this topic is because the ultimate patient for this product is a child. Having said that, the consumer is the parent or the caregiver who needs to choose that product for the child and administer it to them. And so, yes, I have concerns about whether or not a consumer can appropriately pick an OTC medicine, like I do for every OTC medicine. But I don't think I'm overly concerned about this class of medication for this patient population because the introduction's already been made to the marketplace. Now, having said that, I certainly would want to understand. I mean, right now I'm giving you my educated guesses about that the degree of confusion that this would introduce is no greater for this population than it would be for the adult population that's already there. Having said that, I would certainly want some pre-market data to back me up on that.
And what kind of data?
Well, I think in this case, a combination of label comprehension and label discernment studies are likely to be the most useful. I don't really see a difference in actual use behaviors that you would get a lot of benefit from running a clinical study. But I certainly would want good data that helps me understand that the labeling is clear, both in the drug facts label, but also in the supportive labeling. The principal display panel and whatever else comes along with that to help the consumer understand that this is a different product, a different active ingredient, and that they indeed understand that. I'm not familiar with the data that led to introduction of naproxen, for example, to the market for older consumers. But my suspicion is that there is at least some signal of confusion there that may not be enough to offset the benefit of having that on the marketplace. But until we measure it, it's a little hard to know for sure.
Thanks, Russ. Go ahead, Diane.
I was just going to say, Ian had brought up the issue this morning, and I'm not aware either of any data that talks about naproxen being used for fever. So that would be something to be considerate of. The other thing, we've gotten to the point where with acetaminophen and ibuprofen, we can pretty much dose them every 6 hours, and either if you give them together or if you give them in between, it's easy to split the difference to every 3 hours. When you add naproxen to the mix, it has a different dosing interval, which is usually Q8 to Q12. So does that add more confusion for parents about when they can give the other one, or whether we would just have to do that with labeling and understanding when they could dose the next one?
Thanks, Diane. So as we're wrapping up this panel session, I'm going to actually let Russ take the last word because I'm going to ask you one final question. I think it's important. We've talked about a lot of deviations from these existing characteristics for products in the marketplace. And I guess we've talked about the importance of certainly at a minimum label comp, label discernment. I'm wondering, and I don't know if you can speculate on this, but when, based on the deviations we've talked about, when would the deviation rise to the need for the importance of an actual use trial? And can you give a scenario where a self-selection study may also be useful?
Yeah, certainly. The way I would think about the need for an actual use trial is if the new product or the labeling for the new product outlines either a warning or an instruction that you feel is far enough away from the usual sort of established instructions that you need to demonstrate that people actually do follow it. And so could you say, well, I need an actual use trial to demonstrate that people will not give, let's envision a naproxen solution more than every 8 hours? Yes, you could certainly envision something like that. Having said that, in my mind, I don't. It would be similar enough to to the way other medicines are taken, and it would be again established in adult population and an older adolescent population, to the point that I think the only distinguishing feature is that we're giving it to 2 to 12-year-olds instead of to 17-year-olds or 37-year-olds or whatever. So for me, that's the distinction, and I don't see a compelling argument that would say, yeah, you really got to prove that people can do that. If we believe that that adults can take a medicine every 8 hours when directed to do so, what makes us think that is different just because an adult is going to give it to a child? So that isn't to say that there couldn't be other reasons to mount an actual use trial for that, but that's the kind of sort of back and forth that I would have in my own head about that rationale. Certainly, I think for the non-clinical types of consumer behavior studies, label comprehension and so on, you could certainly understand needing to do that because it's a new label and it's a new product, and you want to be able to demonstrate that caregivers can understand appropriately. Self-selection for me is, I guess it depends on whether you're concerned about any particular contraindication for a product, for a new product like that. And again, because I think you're talking about the same indication for an naproxen containing product as you would for an ibuprofen containing product, it's a little bit hard to justify, to understand what you're trying to demonstrate. What exactly are you trying to find out with a self-selection study that is any different from other studies? So I think, not to say that there couldn't be characteristics of a particular product that would drive additional studies like that, but in the general concept of things, I think we already have a product like that on the adult marketplace, and it's well established there, and so really we're just talking about making it available to a younger population. And so from my standpoint, I think it's those earlier label development kind of studies that are most useful.
Very helpful. Thank you. And we're a little over time, so we're going to wrap up. Just wanted to thank everyone for sharing your insight, and also Jonathan, Petrea, thanks for joining us online. Thank you, everyone.